Oh, zero.
Hi, it's Rebecca Griffith, the EDDPT, and we are back on another episode of Admit It or Not. And I'm so excited today to have Dr. Jenna Seagraves with me. Do you want to introduce yourself?
Absolutely. First of all, I just really want to thank you, Rebecca, for taking the time to have me here. I'm excited to be here. So my name is Dr. Jenna Seagraves. I'm a board certified neurologic clinical specialist and a certified lymphedema therapist. I have been practicing for nearly 8 years, and I recently transitioned into academia. I am an assistant professor for a doctor of physical therapy program teaching the neuro content, but my clinical experience includes ortho and neuro outpatient, inpatient neuro, trauma, critical care, obstetrics, and of course, the emergency department.
So you're like me, you're a kindred all patient therapist.
I try to be.
I know for anybody who did not grow up watching Anne of Green Gables, they're going to miss that kindred spirit reference. But I feel like I'm a little low key mad at you for leaving me because you were an emergency
Aw,
department physical therapist at my sister hospital just down the highway, right?
that's right. That's right.
So I'm sure your loss is being felt there, but I'm really excited for your new journey as long as you don't forget about the rest of us.
Absolutely not. Absolutely not.
And I think clearly from your background, you have a lot to offer all of your students, and I hope for sure that that includes the emergency department. So tell me, like, what, how did you end up in the emergency department with all that background?
Oh, absolutely. So I will say the emergency department really you have to have a vast array of knowledge, right? I mean, you are utilizing everything that we've learned about
Mm-hmm.
all through physical therapy school. So everything that we are as physical therapists, you're utilizing that in the emergency department. So I felt as though my outpatient experiences as well as my knowledge of acute care really just melded greatly with the emergency department. Um, I do want to say just one of the things that I really enjoy about working in the emergency department is the collaboration
Mm-hmm.
that's involved with multiple disciplines. So, for example, I speak directly with the referring physician, nurse practitioner, or physician's assistant. And for the first time, I'm really seen for what I am, a doctor of physical.
Yes. Say it louder for the
Yes.
people in the back. Top of scope, doctor of physical therapy.
Yes, yes, and it's just so refreshing to really be valued for my judgment, my assessment, and my evaluation skills.
Yes, 100%. One of my one of my favorite memories is when I went to talk to a resident about something, and then I like looked to the attending and I was like, hey, like I just have these questions. And the attending just smiled, kind of folded his arms and said, well, Dr. Griffith has some questions for you. And that was like such a great moment for me because he was teaching that like next generation of student learners in the emergency department that physical therapists are doctors, that our assessments are to be respected, that our clinical questions are just the same as if we were a neurosurgical resident or a neurosurgical attending. So I thought that was a great experience.
Yes. Oh, wow. Yes, absolutely. Um, I I feel like we have a unique role in the emergency department because not only do we have different skill sets than the other providers, but so we're able to really assess someone's gait, balance, range of motion, transfers, coordination. I mean, the list goes on,
Mm-hmm.
right? But the one of the largest things I think is that we spend time
Yes, what a
with
gift.
people.
Mm-hmm.
We spend time. And when we do that, we're able to identify additional safety concerns, cognitive impairments, other red flags that others may miss. And we can be the ones who uh, either provide the appropriate referral or state that, hey, I think this individual needs a little bit more testing or imaging. So I think we really are crucial to the emergency department to add our skills that we can offer.
I think one question that I have or that I get often is, well, we did this without you before. Why do we need you now? So my question for you is that like we were fine with in the history of emergency departments. There have been emergency departments for decades. Why all of a sudden is the physical therapist crucial in the emergency department? I wholeheartedly agree, but I'm interested in what you would say.
Sure. I have a few things that I'd like to say in response to that. So, one of the first things is, okay, so I hear that you've been doing this before, but how many patients are you getting now? If we were to track the number of visits, ED visits alone over the years, I think it's safe to say that it's increased since emergency departments were ever first, not invented, but you know what I mean, when they were
Yes.
first around. And, additionally, some other questions is how many of these patients are coming back
Yes.
with the
Bounce
same
back.
complaints?
Hmm.
Yes, yes. And, sometimes there are also those cases where maybe a patient came in, there was nothing deemed wrong, they were sent home, and then something terrible happened, whether it was a fall, whether it was a stroke, whatever the case may be, and the emergency department may not know
Right.
those results.
So many outcomes are tracked. So, for example, when you talk about bounce back and are those patients coming back, that is a huge factor for emergency departments, and they do track that. I'll say that the data from our emergency department shows that if you see a physical therapist, you are like, I don't know, maybe 12% less likely to come back to the emergency department in the bounce back window. And then if you see a physical therapist, you are like 50% less likely to bounce back for the same complaint. So that
Wow.
12% is for any reason. The 50%, like if you came in with low back pain, you are 50% less likely to come back for that same low back pain if you already saw a physical therapist. So that right there is really good
That's
evidence to what you're
huge.
saying. 100%.
Yes.
But when you talk about those other outcomes, I mean, there was one example that I can think of is if you do stitches all the time in the emergency department, but you never take them out and you never see that patient again, how do you know that you're good at doing stitches? You may not be. All of your wounds could be dehiscing and you may not know. All of your
Wow.
stitches could be like growing into the skin and you wouldn't know. You know, somebody else is taking those out, someone else is following up with that healing. So I think that's another great question. We do have some knowledge of what happens to our patients after they leave, but do we really know? And are these patients seeking care at another emergency department? Are they
That's a good
seeing their
question.
primary care doctor? Like, so I think that's a excellent point that you bring up. How do we know that we were doing right by these patients?
Hmm.
And I did some outcome tracking for my fellowship program that I'm in of patients that I saw in the emergency department, and I would look them up and see what happened to them in a 10-day window. Like, what
Mm.
happened to you during those 10 days since I saw you? One of my patients, I was surprised to find, had passed away.
Oh,
She was
wow.
very elderly and it was fine. I mean, it was really, she was on hospice, so it wasn't completely unexpected. But that was one outcome I did not anticipate. Other patients, one came back, but for signs of infection and
Mm.
not for anything related to physical therapy. And then a couple of them came back for like the same pain that I had seen them for before. So it is interesting. And if you are working in the emergency department, I would encourage you to track your outcomes at least for a little while to see what's happening to those patients that you've seen. Did you do any of that in your emergency department?
I believe there were some individuals that were specifically doing that. I am not familiar with the actual outcomes. I do have a colleague though that was specifically looking at for those who were having musculoskeletal complaints. Uh, and received physical therapy and had their assessment and then also had a referral for outpatient, how many were actually following up with outpatient, but I
Yes.
believe that's still in progress. So
Yeah. And we've looked at that a little bit. And what I find is you're more likely to go if you've already seen a physical therapist, because hopefully we've gotten that buy in. But on the other hand, there's a reason these patients are coming to the emergency department.
that's right.
Some of that is time, some of that is money, some of that is access. You know, there's so much that goes into that, but that's why I like it, because we can be there for all of those patients that can't access physical therapy otherwise.
That is so true.
So my next question for you is, if you could change anything about how we currently practice in the emergency department, what would it be? What would you do to improve what we already do?
To
We've made it
further
in, we're seen as
improve.
doctors, like what's next?
I would say something that would be helpful. That's a really good question.
Yeah, like what's next?
Let's
If we can
see.
get in there and we have that respect and we're making like a change, like what would be best case for you? Like what's ideal state?
So I think something that would be helpful really is for, first of all hospitals that have an emergency department to have someone who is dedicated to that. Like, think of the emergency department as its own unit, right? So
Mm-hmm.
we have, I think a lot of hospitals, what they end up doing is they're short staffed to begin with. They can hardly cover the regular floors, whether it be, the neuro floor, the cardiac floor. And so if they whenever they get a call for the emergency department, it's like, oh, is it going to be me, or is it you? We only have one person trained, they're not here today. But if we were to look at it as really its own unit, and we have someone who, or multiple people, really, I mean, I think it comes down to physical therapists who work in acute care should realize that they have the tools necessary to work down there. And it should be a matter of more therapists being trained in terms of the exact nuances of the emergency department, certain areas such as vestibular testing and whatnot, if they don't feel too comfortable, but getting the training there, because what happens when the one person who's trained to go down there is out that day?
And that does happen in so
Yeah.
many programs in the United States.
Yeah. So I think if that's great that this area is expanding, but having it seen as its own unit would be so helpful to know we need to have coverage for the emergency department, just like we need to have coverage for the neuro floor. We
Or
need
the
to have coverage for
TKA
the
patients.
ortho floor.
Yes.
Exactly, exactly.
I love that. And I think that if you're listening to this and you haven't started an EDPT program in your hospital, first of all, we can help you with that. But second, that is a huge consideration. Can you staff this beyond yourself? So, what are your like top three must have skills for that therapist that might not be down there all the time, but might be helping with coverage? Like, what are your like must haves?
Gotta have.
Got it. Like,
uh,
you cannot go down there unless you can do X, Y, and Z.
Yes. First and foremost, I would say a vestibular exam, being able to
Yes.
rule in or out central versus peripheral
Mm-hmm.
signs. That's a huge one. We get dizzy consults all the time.
Mm-hmm.
Uh, another key component is just a general musculoskeletal exam. So being able to know if someone with low back pain with radiculopathy, is it a red flag, or does it just seem pretty orthopedic in nature?
Mm-hmm.
So that's another one. Spine, I guess, assessment.
Yes.
And then the last piece really would be discharge disposition, which as
Yes.
acute care therapists, we should really already be well versed in that. But that's another key component. Is this patient just safe to go home? We can't really find too many other things wrong, but are they safe? And
Yes.
that's huge.
I think it's that concept of good enough.
Yeah.
Is it good enough? Or is
Right.
it not going to happen? And I think the
Yes.
only thing that I would add to that, because I think that's a great list, is communication. Because even
That
if
is good.
if you're, gosh, just to totally date myself as a 90s kid, like if you're the bomb at vestibular exams, if you have the best musculoskeletal skills I've ever seen, and you know how to discharge somebody, if you can't communicate that to the team, that patient is not going to get what they need. If you can't communicate that to the patient, they're really not going to have a good outcome. So I would say the only thing I would add to your beautiful list is communication skills.
I completely agree. That's a great add-on.
Now, you and I have discussed the complex patient in the emergency department, and
Yes.
how to, whether that's socially complex or medically complex, or even just the patient themselves, is a little bit difficult. What would your tips be for people that are feeling like lost in the like tornado of complexity with some of these patient populations? Because my experience of you is that you are unflappable.
Unflappable.
Mm-hmm.
I I would say so. If I understand you correctly, you're saying if someone's just getting overwhelmed because this patient just has so many different things going on that they don't even know where to start.
Yeah, and
Is
it
that
just
kind of
feels
what
too
you're saying?
hard.
So I would just tell them to come back to their basics.
Mm,
As physical therapists, what are we doing? Right? First, we need to get a subjective. Is that patient able to tell you what's going on? Are they able to tell you, what their symptoms are? Are they a reliable historian? Do you need to look to their family members for additional information to fill in the
mhm.
gaps? But then also, what do we look at? We look at range of motion. We look at strength. Just start there, and then it will build. You know, we look at basic functional mobility. How are they moving around in the bed? Are they able to sit up? What does their balance look like when they're sitting? And if we focus in on just those key components, then we could, not that we're forgetting about the other pieces, but realizing those other pieces just further add to the picture in front of you.
I think that's the perfect answer.
Well, thank you.
Kind of begin at the beginning and build your way
That's
up.
right.
Yeah,
That's right.
I like
Yeah.
that. And to like not be overwhelmed.
Absolutely. One of the best pieces of advice that was given to me when I was a student, I was doing one of my clinical rotations. It was an integrated clinical, so it was run by faculty. To me, those were even more scary
Right?
than the full time because they know what you should know, and so they're
And they
questioning you.
already have perceptions of you.
Oh, absolutely,
Yeah.
absolutely. And so but one of the best pieces of advice I received was during that integrated clinical when my I I was working on we had a neuro integrated clinical. And so I was getting really stressed out and anxious that I didn't know the exact diagnosis. What does this
Hmm.
patient have? Oh my
What is
goodness.
the answer?
Well, yes, and my clinical instructor just said, "Jenna, sit back, just hang on. What did you assess? What what were your outcomes? What did you find out? You know, do they have range of motion impairments? Is their balance affected? Are they at risk for falls? What is it that you looked at?" And that's all you have to now tell the patient. You do not have to diagnose. You just explain what you found and then
Mm.
what are your recommendations? What is the plan from there? And that was just like, you know,
Well, I
mind
think
blown.
that's also perfect advice for the emergency department, right? Because almost never
Yes.
are we going to know the exact answer. And I think that's another skill that you have to be successful in this area, is to be okay with uncertainty
Yes.
and to move forward without all of the answers. So
Completely.
that was like the
Completely
perfect
agree.
perfect thing. So students, particularly if you're listening, that is excellent advice for any clinical situation, but specifically the emergency department, because it is frustrating when you really want to know the answer to and you can't get there. Yeah.
Oh, for sure.
One of the things that you mentioned in your background is that you are passionate about prenatal and postnatal care. And I think there's not enough of that in physical therapy. And I'm really excited that the House of Delegates just passed a motion about fourth trimester care, largely in part
Yes.
to Dr. Rebecca Seagraves. And
Mhm.
I just want to give her a little shout out for all the work that she did to make that happen. But so talk to me about how you would apply that in this context. Like, what are things that emergency department physical therapists should know about that patient population?
I am so glad you asked me that.
I
One
definitely
of
need to hear the answer.
one of my favorite topics. So I I will say, specific to the emergency department, what any therapist should know, just some kind of red flags to be on the
Mm,
lookout for. If a patient who is still pregnant or within 6 weeks of delivering, they are at risk of having preeclampsia. So what that means, they could be coming in for a headache, they could be coming in because they just feel nauseous.
mm.
So one of the most simplest ways we can look for any of those signs is taking blood pressure.
Vitals are vital.
Vitals. But yeah, vitals are vital. I love that. That's a great saying. And one of the things that as therapists that we should be doing is not only taking the patient's blood pressure before activity,
Mm,
but during and
yeah.
then after. How
Yes.
how is their body reacting? Are there headaches and their feelings of shortness of breath? Is it all associated with activity? There are numerous times where preeclampsia, which can lead to eclampsia, so stroke, seizure, all of these neurological events that go undiagnosed because a lot of times vitals are assessed at rest unless you're a therapist like us and assess these things with activity. So
Critical.
I would say that's one of the number one things that I would highly suggest a therapist do. If you're scared, a patient, you find out they're still pregnant, you're like, I don't know what to do.
Right. Oops.
If it's orthopedic only in nature, once again, do a basic orthopedic exam. But if you're not quite sure, it's not really your arena,
Yes.
refer to outpatient, refer to pelvic health outpatient if you have anyone near, in town who can provide those services so that the patient gets what they need. And then but really it's from with my neurologic background, that is where I am really trying to prevent any of these neurological events from happening. The maternal morbidity and mortality rate in this nation is only increasing, and it is
Mm.
more than double that of all other developed nations.
Why
So
is
just
that?
let that sit with you.
I mean, I can't. Like, like
I
why is
know.
like I
I
can't.
know. Can we
I
all
mean,
just get up and
just to be even more 90s, like I cannot even with this. So like what is why? Why is that a thing?
there there's a lot of speculations out
Hmm.
there. I will say, as a whole, as a nation as a whole, we are not necessarily the healthiest in terms of, eating. We're seeing higher rates of gestational diabetes or
Mm,
younger and younger cardiovascular disease. Um, things
that makes
things of that
sense.
nature. There's also a lot of, s- social disparities of health, right? Like, I
Mm,
mean, just decreased education in general of someone's body, the changes that take place during pregnancy, access to care. There's a ton of, I mean, the list goes on and on. I could go on forever, but
yeah.
um, those are just some of the pieces that are playing a part in why the numbers are where they are. But otherwise, I mean, we may not be able to necessarily change those numbers,
Right.
but we can change the outcomes after. So what I mean by that is, we may not be able to change the fact that this individual has gestational diabetes that then turned into type 2 diabetes
Mhm.
postpartum, or that someone has preeclampsia during their third trimester or immediately in the postpartum. But we can step in and prevent that individual from preeclampsia turning into a stroke,
Yes.
or does that make sense? We
Yeah.
can provide those assessing of vitals during activity or immediately after, and then help them figure out ways to modify their tasks, um,
Mhm.
different ways to identify safe activities that are at their level and then how to progress. And another key part that we really play in the emergency department is that referral piece.
Yes.
We might be able to help catch something to say, doctor, something's wrong. Her blood pressure is significantly elevated.
Hmm.
For anyone listening, preeclampsia, the true diagnosis is any blood pressure over 140 over 90.
Wow.
That's just textbook. But I do want to just throw this out there
Mhm.
that for someone who normally has a resting blood pressure that's significantly lower than,
Mhm.
say, the norm, they may feel signs and symptoms of preeclampsia at a much lower blood pressure.
I appreciate you saying that because I'm a 90 over 50 girl myself. And
Mhm.
so I feel like if I was like getting to 140 over 90, that would be not great. But
Exactly.
I'm sitting
Yeah.
here when you say that, thinking of all my patients that are rolling in at 160 over 100
Right.
or 210 over 110. Like, what if they're pregnant? That's a huge red flag.
Absolutely. Yes, and that's when you immediately let the physician know. And if they don't have an obstetric background, which, unless it's an obstetric emergency department specifically, not every
Yes.
hospital has one of
No.
those. That's when you as the therapist need to know to say to the physician, they need to see their OBGYN. We need to call their OBGYN, or we need to get someone who is on staff here to come and see this patient. I'm concerned.
A friend of mine had her preeclampsia diagnosed by their dentist
Oh goodness.
because their
Wow.
dentist was routinely taking vitals. And so she was hospitalized and had that baby like within 24 hours. So I
Oh my
appreciate what
gosh.
you're saying, that like routine surveillance, and that was at rest for her. So
Oh,
I
wow.
think you're absolutely right. We could play a big role in early identification of that. And preeclampsia, it's not called that after the patient delivers, correct? But they can still be at risk after delivery.
That is correct. So sorry, your question was it's not called preeclampsia?
Right. Is it not, or is it like post-eclampsia?
No, great
Tell me.
question. So it is still preeclampsia because
Okay.
what it's saying is before eclampsia. And eclampsia is stroke, seizure. It's a neurological
Oh,
event. So it could be a brain bleed. Um,
I had no idea. And I'm also a board certified neurologic clinical
no,
specialist.
no, no. Well, that is, we didn't really learn
No,
about that, I would say.
because
So,
I would say that we unfortunately segregate women's health care from all healthcare. Like it's not integrated.
oh yes, if you really want to hear me stand on my soapbox, I think I I love that we have areas for physical therapists to specialize and really become an expert in a particular area. My only fear is that it will be therapists will become very tunnel visioned,
Yeah.
and that's a fear that I have because I personally want to stay as well-rounded as possible.
Hmm.
The emergency department helps you to stay that way because
Correct.
whoever is there, you're coming in, and it could be a cardiopulm situation, it could be neuro, it could be ortho, it could be any and all of these things. So
Pediatrics.
I well,
Pediatrics
I
freak me out just a little bit. I'm not gonna lie.
yeah, I would say pediatrics is kind of its own little world, but if you work at a hospital that sees all ages, absolutely.
Especially in our critical active access areas.
Yes. I will say where I have worked, it's been adult specific. So,
I am supposed to be adult specific as well, but I will tell you with the access issues, and the overcrowding of hospital emergency departments, that includes the children's hospitals. So we are seeing a lot of overflow from the children's hospital to our hospital,
Oh,
with
wow.
families that can't wait, with families that don't wish to wait, with families that think that they'll be seeing quicker somewhere else. It's been a big learning curve for me, particularly in this last year. I've seen more children than I ever have in my whole career.
Oh,
So
wow.
to your point, we have to be prepared for anything.
Yes. Yes.
So I know we just barely scratched the surface on these women who are either prenatal,
Try again.
gosh, God, are expecting patient population.
Yes.
Individuals who are expecting, I'm going to get this right.
That's a great way to say it. Yes.
Individuals who are expecting, as well as individuals who are post-birth.
Yes.
Or even like post-pregnancy, because not everyone's pregnancy results in birth. Correct.
That is true.
Yeah. So
That is
understanding
true.
these things, I think we had a physical therapist who actually in our emergency department was seeing a patient for low back pain and actually was able to help them discover that it was a pregnancy that was being demised. So it was a pregnancy that was not succeeding, and that they got them the appropriate care in the different part of the emergency department after identification of that based on the symptoms. So if people listening to this are like, well, hey, like I really wanted to hear more about that and Rebecca cut you off, how can they find you and the amazing courses that you teach to help specifically with this patient population, whether it's emergency department specific, acute care, or even outpatient? I know that you teach so much valuable information about this.
Yes. So if anyone who's listening is interested in more about obstetric acute care related diagnoses, treatment, intervention, all of that, you can go to enhancedrecoveryafterdelivery.com and you'll be able to find any upcoming courses that are being taught, as well as just information on there as
Perfect.
well.
Because we are unfortunately running out of time. But I know it goes so fast, but I want to make sure that people have that resource, because we just barely scratched the surface on that. And that is such an underserved population.
Yes.
So definitely check that out for more information, and all of that will be linked for you too in the blog for this week if you want to find more information about that. So tell me, it's time for the case. So share a case with us about your time in the emergency department, and we'll try and guess if this patient was admitted or not.
Okay. All right. So let's see. This was a 76-year-old female presenting to the emergency department after a fall while transferring out of her car and into her home after just discharging from the hospital.
Oh,
I know.
It's a hip fracture, isn't it?
Let me give a
I've seen this more than once.
Let me give a little bit more background, because I think it's important. So that caught my attention, and I immediately said, okay, before I go in, I need to just, look in her chart a little bit more. She was just here. What was she here for? Did anyone see her from therapy? All of that. So I'm looking, and, I'm like, okay, the patient was admitted to the hospital. She was there for only 3 days. Her primary complaint was shortness of breath. She was found to be COVID positive, and PT orders were never placed during her admission. She was able to be weaned down to room air before discharging home.
At rest.
I am so glad that was the first thing you picked up on. That was the first thing I picked up on as well. So I go in, I'm going to just start with this. So the patient's very lethargic. She was alert and oriented ×4. But my first thought was, well, let's just see how her oxygen's doing. At rest, she was at 92% on room air.
Okay.
So I'm going to ask you, Rebecca, what would you do?
Well, I would take a history, obviously. I would try to receive that from the patient as best as possible if the patient was kind of lethargic. I would also ask her why she thinks she fell, because I find patients are pretty savvy about that usually. Why do you think you fell? Sometimes I've had that little old lady who says, well, it's the tequila that I drink while I'm watching my shows. And then sometimes it's like, well, it tripped on the cat. So I would probably ask her that. I would want to see the rest of her vitals to see if she's hypotensive at all or tachycardic with that. Sometimes when the rest of your body is fighting to maintain you at that 92%, that could be an issue. I probably would also want to know what she was pulling on the incentive spirometer. And I would look at how she's breathing at rest. Are we accessory breathing? Are we getting that nice resting diaphragmatic breath? And then I would probably sit her up and see what her oxygen looked like just sitting up and see if she became more alert or less alert. How am I doing?
No, that's perfect. All of that. I am on board with everything that you just said.
Great.
So, so history is obtained. She's a reliable historian.
Great.
All of that is looking pretty good. Her breathing is a little shallow. I don't notice that she's really utilizing her diaphragm, but I wouldn't say it's excessive accessory use either. No,
Good.
no.
Okay.
Yeah. So I decided to go ahead and let her sit edge of bed. She's able to do it independently.
Great.
But she did require extra time to put her shoes on. So I did want to just kind of see a functional task while she was sitting. That's when she really was complaining of shortness of breath. And her oxygen went down to 86. So not, it's low. It's not too low. And I only say that because I feel like COVID has changed things where now it's like, oh, I'm not
like 88. Oh, all right.
Yeah. I'm not worried anymore. Right.
Is she having any chest pain with any of this?
She wasn't reporting any chest pain, blood pressure, heart rate, everything looks normal. It's just her oxygen sats. When I asked her too about what happened, why did she fall? She said she felt dizzy. So she did say that she was feeling dizzy when she was trying to walk into her home. So I definitely wanted to look at check for orthostatics as well as checking her oxygen because she had needed oxygen before when she was in the hospital. So we went through a few exercises just edge of bed. We don't even get up. We don't do anything yet. I'm teaching her some pursed lip breathing, diaphragmatic breathing, some thoracic extension, arms overhead with breath. Yes, we could all do a little bit right now. I was like,
ooh, I need a little thoracic extension myself. Okay.
And her oxygen did improve to 93%, which is great. But I also in the back of my mind was thinking, but I had to guide her through all of this. And it did. It took effort, and she was not initiating any of these things on her own. So what's the likelihood that she was doing any of these things during the hospital admission, right? Trying to walk into her home, all of that.
But I also think that's a little too much to expect for somebody who's satting at 86% to have the cognitive awareness to sit and work through that unless that's baseline for them. I do have those COPD patients who come in and they're they know they have a checklist of things to try and things to do and things to draw their awareness to. But if this is new and they're hypoxic, I can't imagine that being a toolbox that she has in place.
Right.
So then what did you do?
Yes. So, oxygen was now at a better level. Nothing was changing with her arousal, level of alertness. It was still, she's there. She's able to answer my questions. She just seemed a little delayed, just sleepy, lethargic. So we're able to stand. She's able to stand up, but she could only walk about 5 feet before she lost her balance, required physical assist to correct, immediately sat back on the edge of the bed, and her oxygen was at 76%.
Okay. So
what are you thinking?
I'm thinking that perhaps she does not need to be admitted. But she definitely needs to be evaluated for home oxygen use. But I'm going to say it's not good enough, and that I would probably refer this patient if she had been independent at baseline and has the tolerance to post-acute rehab, because our COVID patients deserve a little bit better than us sending them home at 92% at rest. Because, and especially, and we have a webinar available for people about older adults in the emergency department. And I think you're 100% highlighting why the emergency department is not necessarily the best place for older adults, or even hospitals in general. So I would want to make sure that that patient has what she needs to succeed. She's already been back once, she's already experienced one fall. So I would recommend oxygen with activity, and I would refer her for post-acute rehab. And I would make a referral to the occupational therapist to help them assess her activities of daily living, because she's clearly not able to be functionally independent at this time.
Rebecca, I love everything that you just said, and I am in complete agreement. That was my exact plan. So
Love it.
I love it. I love it. And I
2
am
out of 2
so
EDPTs agree.
yeah, right. I'm so glad that you also brought in occupational therapy,
Yes.
because they really are crucial. They are they're our teammates. You
Mm-hmm.
know, I mean, we work so closely together, but also, when I saw that she was really struggling to put her shoes on, I'm thinking, oh my gosh, how's she going to shower?
Well,
Like, I
how
mean,
are you
how's she
going to
going to?
stand there and cook
So many
after
things.
you've showered?
So many things. And so, yes, all of this was relayed to the doctor. And really, what I try to focus on when I'm in the emergency department is, in this moment, can the patient go home? If so, what does the patient need?
Yeah.
Or is it just, it's not safe, because before she goes home, she's going to need to be assessed by respiratory therapy.
Correct.
They need to see, is there any other medical treatment that she needs? Maybe.
Mm-hmm.
I don't know. That's not my area.
Right.
Um, and she does need continued inpatient physical and occupational therapy, at least, to be able to do a little bit more. She only did 5 feet. What's that? How's she gonna?
Well, she didn't even
How's
make
she?
it into her house. So clearly
No,
not
she
a
didn't.
successful discharge. And I think
Exactly.
if this were my patient and she refused to go to rehab, as sometimes our patients do, which is absolutely
Mhm.
their choice, then I would probably, in this case, recommend that she had supervision at home and as many home services as possible.
I agree. Possibly even a walker, or an assistive device, just to help a little bit with that functional endurance.
Correct.
Maybe,
And
you
in that
know?
case, I would probably choose a four-wheel walker so that she could sit and be able to help her with her activities of daily living a little bit better.
Yes.
Yeah.
Yes, great. So they did end up admitting this patient.
No.
Oh, they did. They did.
Was
Yes.
it for a medical reason or a placement delay?
More so placement.
Shoot. See, I'm gonna have to have a whole nother podcast episode on how we can improve transitions of care from the emergency department.
Yes. Yes. Well, and I also think that we need to open the doors a little bit to occupational therapy also being in the emergency department, uh, because that is where I was, that was a large barrier. We didn't have
Hmm.
any occupational therapists who felt comfortable. No one was, quote, trained to go down.
Right.
So the patient had to be on a floor. So if we were recommending acute rehab,
Oh,
they need that other evaluation. They cannot
that's not
just,
great.
I'm just being
Yeah.
honest.
Yeah, no, I think I appreciate that. And if you want to learn more about occupational therapy in the emergency department, our first podcast episode was actually with an occupational therapist in the emergency department in honor of Occupational Therapy Month, which was in April. So you can
Whoop,
definitely
whoop.
go back and listen to that episode with Julia Smith. She's a fantastic occupational therapist.
Oh, I will
Hear a
do
little
that.
bit more about their role in the emergency department and kind of that fight to get them added. And the literature about occupational therapy in the emergency department is also growing, particularly as it pertains to our unhoused communities, which I think
Wow.
is fascinating. So
Great.
definitely listen to that. Um, just to wrap things up, any final thoughts from you?
Final thoughts.
Yeah, I know. Well,
Um,
not final thoughts, but closing thoughts.
my don't forget your basic skills as a physical therapist.
Hmm.
They will come into play regardless of the setting that you're in, the patient condition, diagnosis, all of that. Um, And don't forget about assessing vitals.
Because
They're
vitals are
vital.
vital. Yes. Thank you so much, Dr. Seagraves, for joining us
Of
today. It
course.
was so nice to have you. And if you are listening today, I appreciate you listening. Feel free to like, share, and subscribe so we can continue to bring you great content. And we will see you next time. Thank you so much.
Thank you. Thanks, Rebecca.